Hi everyone, my name is Jennifer Oshita and I'm a postdoc fellow at NYU Langone in the Department of Rehabilitation Medicine. Welcome to this applied learning case on learning health system methods to advance health equity. My case I'll be sharing with you today comes from my LeaRRn Scholar year working with Spalding Rehabilitation. We addressed adoption of social needs screening at their large inpatient rehabilitation facility. I want to take a moment to thank the LeaRRn team at Spalding. We called ourselves the Shine team, and this includes Dr. Chloe Slocum, Dr. Mary Slavin, Dr. Carla Hendricks, Shanali Gaudino, and James Green. I also want to thank the LeaRRn group for making this project possible, as well as the Spalding Health Equity Council, who really was the impetus and started collection of social needs at Spalding. I also want to thank the case management and social work group for their support of this project, and of course my home team over at NYU Langone, our lab, Dr. Megan Morris, Aaron Beatty, and Ellie Milor for their support in allocating time and administrative resources to complete this project. So on the docket today, we have a background of this project, which includes some definitions on what we mean when I talk about health equity and how health-related social needs fits into that definition. And then from there, we'll go into this applied learning case, applying this health equity concept. All right. So health equity. What is the definition for health equity? It is the state in which everyone has a fair and just opportunity to be as healthy as possible. And I know equity has become a charged word today because it does have an important moral and ethical thrust to it. But on the flip side of health equity, there's a very neutral component, which is just let's make sure we strive for accurate measurement. And that's accuracy in what we attribute the causes of our health outcomes to. And once we get accurate attribution, we can thereby dedicate resources most efficiently, or take action in the most efficient manner. And this is not a new concept, right? In clinical trials, using statistical analytical terms, this is called heterogeneity of treatment effects, which is a non-random variability in the direction or magnitude of a treatment's impact across individuals in a population. And this concept recognizes that medical intervention, social policies, or other treatments often produce different outcomes for different people, even when administered uniformly. And therefore, we need to be sure that we're stratifying by important sociodemographic characteristics that may be a reflection of broader social contributors to the health outcomes that we're seeing, so that we can really separate out the social from the medical factors and then efficiently distribute resources according to that assessment. And this slide is just to say that this efficiency is highly needed in the US healthcare system. In the US, so here we have health outcomes here. And these are our inputs, right? And these are our outputs. So in the US, our inputs, we spend the most on healthcare per person. So this is in this clinical care box here, the second box, as a share of our gross domestic product when compared to other high-income countries. And although we excel in some of our healthcare process measures and we have top hospitals, our overall population health and health outcomes really lag behind many other developed and even some middle income countries. So, from a broader population health perspectives on inputs, we're spending a lot on healthcare, but on outputs, we aren't seeing the return on our investment. And as you can see in this diagram here, this makes sense because from what the evidence tells us, that clinical care only attributes or only causes 20% or contributes, to 20% of our health outcomes, whereas non-medical factors here can contribute up to 50% of our outcomes. So a diagram like this just helps us to differentiate medical care from the social factors contributing to health outcomes, which can lead to more accurate attribution of causes as well as more efficient courses of action, as we talked about in the prior slide. All right, so much of the early literature on social determinants of health, so we've talked about that social factors contributes to a large proportion of our health outcomes, and a lot of that literature has been in the public health arena, focused on the community upstream conditions or social determinants of health, which are the conditions that we live, work, play, and age. And so more recently, healthcare delivery systems have been turning their attention. They've been wanting to look at social factors, but it's hard for healthcare delivery systems to be assessing community conditions, right? That's not our area of specialty as healthcare providers. However, what we can look at and address are the individual level effects of community conditions or the individual level effects of social determinants of health. And these are called health-related social needs or social risks. And examples of these social needs are food insecurity, housing instability, and unreliable transportation. So they are adverse factors toward health and healthcare access. And the beauty of collecting this data is one that it is collectible at an individual level, right? It's going to be hard for us to ask our patients what is the community that you live in like, but we can ask them directly, are you experiencing food insecurity or unstable housing? And so that is measurable at the individual level for us providers in healthcare delivery systems. And then in doing something about it, we can immediately do something about this data that we collect. We can provide patients with resources and referrals to community, state, federal programs and resources that address any unmet social needs that we identify through screening.
So, is this pertinent to the rehab population, right? How much do unmet social needs impact the patients that we serve? And the truth is, we can't answer for certain because we aren't routinely and systematically collecting social needs across rehab settings, hence the impetus for this project. But we can look at the population of persons with disabilities to get a sense of this. So my colleagues and I looked at the prevalence of unmet social needs among persons with disabilities using the National Health Interview Survey, which is a nationally representative survey of U.S. adults in the community. And what we found was that the odds of having unmet social needs are 1.5 to 2.5 times higher among adults with disabilities as compared to adults without disabilities. So you'll see in these forest plots, we have 4 forest plots broken down by disability type of any difficulty communicating, any difficulty with self-care, any difficulty seeing, and any difficulty walking or climbing steps. And on the y-axis, we have the type of unmet social need, whether it's in transportation, housing, internet, medical bills, food, medical care, or medication, or obtaining medications. And you can see that for all of these needs and across disability types, with the exception of internet, that the odds of having unmet social needs for people with disabilities as compared to those without disabilities, and that would be on this 1 odds ratio, meaning there's no increase in the odds when you're comparing the 2 groups. So we have the point estimates here, and then our confidence interval rings here. And so all this to say that unmet social needs is a highly pertinent issue to the rehab patients that we serve. And when we think back to the drivers of health outcomes and the overall poor health outcomes of the US population, knowing that social needs heavily drive health outcomes and that these are the patients we serve in rehab settings, we as rehab providers in rehab settings have enormous potential in improving overall health outcomes for patients with disabilities. Now, at national and state levels, policies are being put into place to support this practice, and many have already been put in place. So, for example, in Massachusetts, Mass Health, which is the state's Medicaid program, has a waiver, the 1115 waiver, to reward health systems for collecting social needs data. The Joint Commission has included in their elements of performance that health systems must have some type of processes in place to collect social needs. The Office of the National Coordinator for Health IT, which is the federal authority on health IT for our national health system, it requires that all EHRs have standardized builds to collect social needs data, and the NCQA, or the National Committee for Quality Assurance, in their HEDIS measures also collects social needs data. So there is this national and growing recognition of the importance of collecting this data. So now that brings us locally to Spalding Rehab and our project Adoption of Health-Related Social Needs Screening in a large inpatient rehab facility. So this was a 1-year project beginning in May of 2024, and Spalding Rehab had already piloted screening for social needs back in 2023. However, they were noticing variable adoption of this screening practice. And so when I came on board as a scholar, we decided to make this the focus of my scholar work. And we decided ultimately to focus on the inpatient rehab setting, as there was relevant policy at the time of CMS passing a final rule mandating collection of a more comprehensive set of social needs in the inpatient rehab facility. And that has actually been rolled back a little with a more recent proposed rule in April of this year, retracting mandating of those rules and citing that as the rules, as the questions stand and as the practice stands right now, it may not be fitting for the rehab population. So in our study here, we used implementation mapping, which is a systematic process to identify determinants to implementation and also to design strategies to address those determinants. So part one, we conducted a needs assessment, and then part two, we received additional funding to work with stakeholders to co-create implementation strategies to address those determinants. These are the social needs screening questions being used at Spalding Rehab. They are an amalgam of the accountable health communities, social needs screening, and the prepare. So as you can see, they cover 5 areas of social needs. They are asked upon admission to the inpatient rehab facility, and case managers are the primary screeners, or assigned to be the primary screeners of this questionnaire. In theoretical models, we topic-wise on the content of social needs, we use the National Academies of Science 5A's model, and we honed in on the goals of the screening are to, one, build awareness, a systematic awareness of patients entering the rehab setting with social needs, and that should then result in assistance. So providing patients flagged as having a positive social need, meaning an unmet social need, are provided with resources and referrals to community, state, and federal programs and other resources. And then in terms of our methods on how we guided our project, so we used the implementation mapping process. And so that consists of, as I had mentioned, a needs assessment followed by the co-creation process. So for our needs assessment, what we did was we used the PRISM. And the reason why is it's connected to the LeaRRn. So it connects to an outcomes-based implementation framework, which is kind of nice because then we could kind of reverse engineer our needs assessment. So what we did was we first collected quantitative data on the outcomes of REACH, so what percent of patients were screened for social needs, and then adoption, so what percent of screenings done were done by case managers and other clinicians. And then for REACH, we also further stratified the data by sociodemographic characteristics to see if there was any differences by those characteristics, and we did not find that there was. Ultimately, because this is a talk primarily focused on equity, I'll just skim over this, but essentially we ended up, based on our quantitative findings, determining that adoption at the level of the case manager was really where there was the voltage drop in the screenings. So in our qualitative analysis, so this is here, this part where there's the context of healthcare, and you can see there are different levels, staff, managers, leaders, external environment, implementation, and sustainability infrastructure. So these are just kind of parameters or ways to break down how to understand contextual determinants. And so we ended up focusing on our interviews primarily on clinicians. We looked at their characteristics as well as their perspective on the social needs screening intervention in this case. And secondarily, we also did talk with some nurses and social workers as well as patients to just get a rounded sense of the contextual factors contributing to ultimately to adoption. This is just another way of looking at what I just talked about, where we did the needs assessment, quantitative, led to more focused qualitative interviews, which We had a year to do this project, so we couldn't be fully comprehensive. We had to hone in on the highest yield stakeholders to speak with. And then finally, that led to the co-design, working with case managers. So these are the results of our qualitative findings. So one, the social needs screening practice was distinct from prior practice. So, I asked them about, why is this practice difficult? Isn't it the same as what you've already been doing when you work with patients? And they said, no, it's different. It addresses a broader set of social risks impacting long-term health, whereas before we were really focused on just the social needs, addressing barriers to discharge. So it moves the goalpost further down the road in terms of the thinking about the health outcomes that we in the rehab setting are responsible for. And then theme 2, clinicians and patients expressed some discomfort with the screening questions related to how they aligned with the inpatient rehab setting and the goals in the setting, as well as privacy concerns. And then finally, in the third theme, and most pertinent to this talk on equity, case managers felt unprepared to address this broader set of needs that is more holistic and thinking about the longer term health and rehab outcomes. This is especially true related to disability specific access and community resources. So we're going to focus on this third theme for this talk on equity, because it talks about, it really shines a light on disability access and community resources. We thinking about us as rehab providers, not just responsible to see functional gains, which is important, but even beyond that, when someone is living with a disability, how are they meeting their basic needs? And so this is an example of what we did in our co-design step, which is after we identified determinants. So we broke down each of these themes into determinants. So this is the unprepared theme related to not having enough disability-specific access and community resources. And we broke determinants down into insufficient resources that show, for example, not just food banks, but maybe food banks that could support or had capacity to individualize food availability by dysphagia diet, let's say, right? Like what do you do about referring a patient with dysphagia to a resource for when they have food insecurity if they have dysphagia, as one example. And then patients with cognitive and communication impairments struggle both with the screening questions and with navigating the administrative component of community resources. And this pertained to not just patients with new acute rehab conditions like stroke and TBI, but also those who came in with an existing communication or cognitive disability, whether it was hearing or age-related cognitive decline, right? Those all affected their ability to partake in this intervention of social needs screening. And then we came up with potential implementation strategies to address these disability-specific, access-related determinants to screening and adoption of social needs screening. So one was building knowledge and skills of the case managers through a social needs training. Another was providing more supports in resources that the case managers could give to their patients when referring them to community and state and federal resources. And so Spalding leadership actually did work with case management to develop these worksheets that were designed to provide a list of resources by disability type. And then supports for disability access, other supports to provide communication accessibility of the screening, as well as the addressing of unmet needs through community resources. One was SLP collaboration, potential SLP collaboration for patients with these more complex cognitive communication needs, as well as thinking about how to adapt wording and administration methods, and maybe again collaborating with SLP to create these in more systematic ways so that all case managers can have access to these resources. All right, so these I highlight these determinants and these strategies because actually CMS did a similar thing by marginalized populations, and this is tiny, but you guys can see here they did it by patients with behavioral health needs, elderly patients, patients with disabilities, patients with low literacy, and they even have one for patients with disabilities. And and the CMS guidance said that staff may have unconscious biases or make assumptions based on patients' ability. And again, remember that a lot of the social needs literature out there right now is based on primary care setting as well as the acute care setting, but really little has been done in the rehab setting. So, and this column here are potential strategies. So CMS says you can enlist the expertise of diversity and inclusion committees to train staff on respectfully engaging patients with disabilities, and ensure that staff allow extra time to accommodate visual, hearing, or cognitive impairment. So you can see similarities in their approaches and their strategies to what we found. So I just put in here our findings to just add on to this list here. But in addition to enlisting the expertise of inclusion specialists, you could enlist the expertise of SLPs in terms of accessible ways to provide screening and referrals, as well as the disability-specific community resource worksheets. All right, so equity takeaways from this presentation. You can really find that across our background, methods, findings, and just overall equity implications. So in the background, the impetus for this work was really an equity-driven one, in acknowledgement that screening for social needs is one way to advance health equity. And then in our methods, we use the National Academy's 5 A's framework, as well as implementation mapping, which is a bottom-up method to co-design strategies to solve an implementation problem rather than a top-down. And we use PRISM. And then in our findings, I think the major finding is to really think about how are we factoring in accessibility of social needs screening as well as resource referrals for our patients in rehab settings, especially those with cognitive and communicative disabilities. And then in just overarching equity implications and the importance of the rehab setting, I think that all of this speaks to us as a setting and providers and researchers that we are a potentially influential touch point in addressing social needs for people with disabilities.